Uh, Good morning, everyone. I want to thank to the organizers for this kind invitation to talk about the use of virtual chromoendoscopy, SFI, and BEAST in the diagnosis of gastric premalignant conditions. I am Pedro Delgado Guillena. I work as a gastroenterologist at Hospital of Mérida in Spain, and also as an invited professor at in the University of Barcelona. I have nothing to declare. This is the content of my presentation. At the beginning, I'm going to talk about the gastric carcinogenesis from the point of view of the histology and endoscopy. And then I'm going to talk about the virtual chromoendoscopy by Sonoscape, SFI, and BEAST. And I will show you some videos and pictures obtained with this technology. This is the histological gastric carcinogenesis model. Maybe we all know about the Correa's cascade. This is a very well accepted model around the world. In this model, we can see how the normal mucosa is infected by H. pylori, and this bacteria induces some chronic inflammatory changes, and this inflammation progress to some gastric premalignant conditions, as could be atrophic changes, metaplastic changes, dysplastic changes, and finally adenocarcinoma. At least in Europe, we all agree that the dysplasia deserves some kind of intervention, at least by endoscopic surveillance. But it's not the same for intestinal metaplasia or atrophy, because the risk of to progress to gastric cancer is lower than dysplasia. However, the European guideline has recommended an histological stratification by doing gastric protocolized biopsies in the first-time diagnostic upper gastrointestinal endoscopy to stratify and identify the patients who deserve surveillance. In this way, and by using histology, these two systems, Olga, Olgin, we can see or identify these patients. So our patients at higher risk for developed cancer will be patients with Olga 3 for atrophy and Olga 4 for patients with intestinal metaplasia. As we can see so far, in Europe, we have an histological identification of these patients, but we can ask ourselves two important questions. Is it feasible to identify these histological changes by endoscopy? What's more important, could be possible an endoscopic risk stratification in Europe? My particular answer is yes, we can, because in the last years, we have seen a good correlation between endoscopic classification and histology. For example, we have seen a very good correlation by using the Kimura Takemoto classification and histology. And we also have seen a good correlation by using the aging classification and histology. And we also have seen that the Kimura Takemoto, the severity of this classification are related to the risk of the patient to develop gastric cancer. The same we have seen when we use the aging classification. We have seen that patients with more advanced score in this endoscopic classification, more is the risk to develop gastric cancer. But our European guidelines recommend to use this endoscopic classification after a proper training. I have to say that in Europe, we don't have validated training for this endoscopic classification. But even though you are a very trained endoscopist, the European guideline recommends that it's mandatory to do biopsy. Well, to use these endoscopic classifications, we need to be familiarized with the most important gastric findings, including the normal findings, atrophic findings, metaplastic and dysplastic findings. So similar to the histological gastric carcinogenesis model, we can integrate all of these findings, endoscopic findings described until now in a integrated model. This model that we can call the endoscopic gastric carcinogenesis model. So in this model, I try to integrate all of these normal findings, the atrophy by using the Kimura Takemoto classification, and the intestinal metaplasia by using the simplified MBI classification and the aging classification. And of course, the dysplastic changes or lesions by using the Paris classification, the basal flat surface classification, and the Mesdache algorithm. But before continuing with the description of these findings, it's very important to know how does SFI and BIS chromoendoscopy work, because it's very important when we are doing a gastric endoscopy. Sonoscape is a new brand in Europe. It's a baby brand in Europe, but it's very comparable to other important brands like Olympus, Pentax, and Fuji. Sonoscape in the last version offered us a high definition image. The light of source of this last version is based on LED, which allows the direct generation of light. And the principal chromoendoscopy, the BIS, is similar and works similar to MBI from Olympus or BLI from Fuji or E-scan optical enhancement mode 1. And in this new chromoendoscopy SFI, which the objective of this chromoendoscopy is increase the contrast of the lesion, works similar to LCI by Fuji or E-scan optical enhancement mode 2 by Pentax. Even though the TXI of Olympus works in a different way, the objective of this technology is the same, increase the contrast. So to a better understanding of this virtual chromoendoscopy, it's very important to know the mother of all of these chromoendoscopies, which is narrowband imaging. In the narrowband imaging, the originally works by using a xenon bulb, which produces a sort of white light, and then by using an optical filter, we could obtain the blue spectrum, and this blue spectrum is projected to the gastric surface, and then the image, how this signal or how this spectrum is absorbed in the gastric mucosa, this signal is received and suffer a process by a digital process. So this is the model of all of these virtual chromoendoscopy. But in the case of this chromoendoscopy, the physics principle is the same, but with some variations. Like we can see here, instead of use a xenon bulb, in the case of this, we use a LED source of light. Instead of using an optical filter, Sonoscape use directly light spectrum generation, and they use also a digital processing phase by using an owned algorithm. In the case of SFI, the spectral focus imaging, as I said before, the objective of this chromoendoscopy is increase the contrast by allowing the red areas appear redder and white areas appear whiter. So this mechanism allows an easier recognition of slight differences in color of the mucosa. And the principle in the case of the LCI and SFI is increasing the intensity of the blue spectrum, in this case, the blue-violet spectrum. So in this first experience, in a single endoscopy experience in Europe, as far as I know, this is the first publication in Europe and in the world in this area. We have published our results as a scientific letter, and we could observe that the accuracy improved after our first endoscopies, and also our sensitivity. And in this second experience, where we have enrolled more endoscopies, 4 in total, even though the accuracy was lower, we could still see that the sensitivity is very high, with a high negative predictive value, which allows us to reduce the risk of missed patients with high-risk gastric premalignant conditions. But if we want to improve our optical precision accuracy, we need to improve our knowledge about the gastric findings. So we need to be very familiarized with the findings of normal mucosa, for example. In this case, the collecting venules is a very important and simple finding. If we can see the distribution of these collecting venules in a regular way, on a regular distribution, is an indication of a normal mucosa or non-infected gastric mucosa. Another normal finding is the funding gland. That this finding is usually seen in the body and the fundus of the stomach. And in this part of the stomach, it's easy to identify because these glands are distributed in a perpendicular way. So it's very easy to recognize the crypt opening as a round pattern. And surrounding this round pattern, we can see the subepithelial capillary. In this video, we can see by using the sonoscape technology with white light and SFI how the collecting venule looks like with SFI and also with the beast mode. And we can also see in this part of the stomach, in the body, how the normal mucosa looks like in a way of round pattern. In the case of pyloric gland, the antrum is a little bit more difficult to recognize because the distribution of the glands are oblique in this part, so the crypt opening is not seen normally, and the subepithelial capillary is in the central part, surrounded by the marginal crypt epithelium. Here we can see the photos of these pyloric glands in the antrum by using white light, SFI, and beast. Now I'm talking about atrophy by using the Kimura Takemoto classification. This classification has been described and validated in several studies by using white light, and it consists in identifying the atrophic border. We can see here by using SFI that the identification of this atrophic border is easier when we use this chromoendoscopy modality. And here in this video, we will see the different stages of the atrophy by using the Kimura Takemoto classification. In the C-type 1, we can see the atrophic border limited to the antrum. And in the C2 type, we can see that the atrophic border could affect the distal part of the lesser curvature, as we can see in this video. Next, in the C-type 3, we can see that this atrophic border could reach to the proximal part of the lesser curvature of the gastric body. And then we will see the open times that are considered the more advanced ways of atrophy. Atrophy in this classification, the O type 1 affects all the lesser curvature reaching to the cardia, and then the O type 2, the atrophic border is affecting the anterior or posterior wall of the gastric body. Of course, SFI increase the contrast of the normal or anatrophic mucosa, and then the O type 3 affects the greater curvature of the gastric body. What about intestinal metaplasia? In the literature has been described 3 important findings to identify intestinal metaplasia. One of them is the papillary bigiform pattern that looks like in this way, the light blue crest that it is possible to identify by using magnification. When we use high definition, it's a little bit difficult to differentiate this light blue crest from the marginal crypt epithelium. And the another finding is the bluish whitish area. So here we can see again these findings by using white light, SFI, and BIST by sonoscope. And here we can see a video in real time how these findings look like. This is the bluish whitish areas under the 3 modes of sonoscope. And now, finally, I'm going to talk about dysplasia. To looking for dysplasia, we need an approach. And the approach that has been proposed and validated is the vessel plus surface classification proposed by Dr. or Professor Yao. To use this classification, we need to use magnification, and one important part of this classification is the identification of the demarcation line. So after we can identify the demarcation line, we need to observe closely inside this demarcation line, looking for the regularity of the glandular or vascular pattern. So if this pattern is regular, we probably will be facing a non-dysplastic lesion. But if we can see some irregularity, we probably are in front of a neoplastic or cancer lesion. So, but I think most of us don't have the availability of magnification in our endoscopy unit, as my case, as is my case. So, but we can also apply this same approach, but instead of using a demarcation line that must be used under magnification, we can see by for a boundary line that of some of the delimited lesion. I mean, by using high definition, it's possible to detect lesions, and we can see after it identify the border of the lesion, look closely inside this boundary line. So, for example, in this case, we can see a photo of a lesion. If we identify this lesion, we can see inside the boundary line for the regular distribution of the glands or the vessels, and we can see here a round pattern which reminds us of a normal mucosa. And here we can see a flat lesion, and inside of this boundary line, we can see a pattern, a tubulovinous pattern that reminds us of intestinal metaplasia. And here we can see 2 lesions, 2 delimited lesions, and inside of this lesion, we can see some irregularities of the distribution of glands and vessels. So we are facing a neoplastic lesion, and in this case, it was a low-grade dysplasia and high-grade dysplasia. And here we will see in real time inside the boundary line of this delimited lesion, and we clearly see irregular distribution of glands and vessels. And finally, this is our last lesion. After we have identified the lesion, we look closely for the boundary line, and following the vessel plus classification by Professor Yao, we can see inside this boundary line, by using high definition without magnification, the distribution of these lesions. And here in this lesion, in some part of the lesion, we don't see any kind of distribution. So we are maybe in front or facing a more advanced lesion. And this lesion was resected by ESD, and this lesion was compatible with adenocarcinoma, non-invasive adenocarcinoma. So finally, these are my conclusions. My conclusions in a way of take-home messages. I could say that gastric premalignant conditions can be identified by using high-definition endoscopy and virtual chromoendoscopy, the endoscopic carcinogenesis model, similar to the histological carcinogenesis model. Secondly, SFI and BIS share similar physical principles to other chromoendoscopic brands. There are validated endoscopic scales which allow us to diagnose and rate the severity of gastric atrophy and intestinal metaplasia. And finally, vessel plus surface classification could be also applied by using high-definition endoscopes and by identifying the boundary line of the limited lesion. Thank you very much for your attention.